Thank you all for being here for our weekly COVID media update. Today we have our regular featured speaker, Dr. Cliff Robertson, President and CEO of St. Francis Health System. He'll be joined by Christy Pissarra, who is our Director of Patient Care Services for St. Francis Hospital, and Dr. Abbasi, who is one of our inpatient hospitalist physicians who has been solely treating COVID patients for the past 2 years. So we will start with Dr. Robertson.
Thanks, Lauren. And just to run through our data just in a bit of a reverse order in terms of the slides. So this is from today. You will see that we have 369 COVID inpatients across the St. Francis Health System. What you may notice is the average age of our inpatients is up a little bit, and we do have a few more patients than our last call on requiring mechanical ventilation on the ventilator. The next graphic will show you that as of Monday, we were at 392 patients. So we are down a few over the last couple of days. I've been able to watch that because I see a report every morning showing the number of COVID admissions we'd had in the prior 24 hours, as well as the number of discharges. And really, due to the amazing work of Christy and her teams and Dr. Abbasi and his colleagues, we've been able to actually discharge more patients than we've admitted for the last 2 days. So subsequently, our number today is a little bit less than where we were on Monday. And this slide just shows you again, comparing this year to the same calendar period last year. We have exceeded what we had seen in prior waves in terms of the number of patients requiring hospitalization. I think that's it for me. I'm going to turn it over here to Christy Pissarra. She's one of our nurse leaders, and she can brief you on what she's seeing from her perspective.
Thank you. Good afternoon. Thank you for the opportunity to come and share with you. So here we are in another surge, and it's been a wild ride. So we have more patients than we've ever had before, per the graph you just saw. And it's quite, it can be challenging at times. At the same time, it's requiring great creativity to try to figure out how to navigate it. The Omicron variant seems to obviously have the pattern of being so incredibly contagious in our community. And that is significantly impacting, as well as the community, our hospital workers. And that's probably the biggest difference I feel in this wave so far for managing the hospital, is just the number of staff that are impacted with being out ill. I will say we're being as aggressive as we can with kindly encouraging them with employee health to stay in communication and return to work as soon as it's safe. And it's not just nurses, it's all job classes. I know it's all industries in our community, our schools and other things, but for sure here at the hospital, having to absorb the impact of staff out sick with their family members or themselves has definitely been unique to this wave compared to the previous waves. Kudos to our teams for being incredibly flexible. They're covering for areas of the hospital that they wouldn't normally cover, but at this time it's one team, one mission. We are trying to help wherever we can because the patients are here. The pattern of critical care, which I think the physician that's on the call will share more about, seems to be less of the severely critically ill and more of the moderately critically ill. And so the patients, we still have patients on ventilators, but we have a large patient population on the ones where they're the external ventilators. So we're able to hopefully keep more people off the ventilator. And then the more mild patient, we're working very, very hard to get them home. So whether that be home with oxygen or home with additional monitoring at the house, we are working very hard that patients that once they are stabilized here in the hospital, we can get them back out and back to their home as soon as possible. The pattern of failure, the patients, like Dr. Cliff said, are just a little older. So it feels like a mix of the two previous surges we've gone through. At the same time, patients that have severe illness from COVID, it still can be a significant and a long recovery. We have patients that are just now being discharged that showed initial symptoms back in the summer. and have been in the hospital for the last couple months. So we still see a trend of some of the young expectant mothers in the hospital. I would like to share a success story that around December, we had a patient come in that was 6 months pregnant, and we didn't know if she and her baby were going to make it. And I'm happy to report she's in our rehabilitation unit now here in January. And we look forward to seeing the picture of her as a healthy mommy and a healthy baby this spring. So we're holding on to the hope that we'll have success stories and patients that come back and can share with our teams about being back to normal in their life. So very much as a hospital, we've had to, I think, figure out how to learn to manage a surge. So I would say communication and everything we've learned through previous surges, we have in function today, whether that be the coordination with our teams to case management, social workers to try to help with our physicians and external partners in the community get patients discharged, but also kudos to our supply chain people right now. In a national supply chain shortage, the idea of not having the supplies you need when you need them, manufacturing back orders can be challenging, but our teams have done an amazing job of, we know during a COVID surge, the specific items that we use more of, and they have worked very, very hard to make sure that our nursing and physician staff have what they need to take care of the patients. So very proud of that. I would say some of our units have been COVID for 2 years. So I think maybe the acceptance that we as a hospital and going forward will care for COVID on the long-term effect and always be ready to take care of patients with COVID. Again, we're always working to try to get enough patients out of the hospital, transitioned out of the hospital safely to the community in order to make room for the number of patients that have been coming in, because it's staggering numbers to try to absorb the number of patients per day that have come in and needed the hospital. I'd like to again say thank you to our teams. They come here because this is their job, but it's also their calling, and we come here for each other just as much as we come here for our patients. And so without them doing that, we wouldn't be able to do what we do. This wave has the flavor of distance learning with it. And so many of our caregivers, maybe myself included, have children at home, and we are trying to balance the work needs me for overtime and extra hours, but yet I do still have to help my kids do homework at night. I'm going to have to be their bus driver because their bus drivers are out sick. And so, just the reality of that, or caring for caregivers, you're the caregiver for an elderly person. That's very real, but we come here because we enjoy what we do. Some days are harder than others, but we really, we come here for each other. We really appreciate that too. Trying not to lose the fact that we're not going to be here forever, that we are going to keep our head up and have hope that we're peaking, and that if we've made it this far, we're going to be able to get to the end of it. And at the same time, we're also hoping there's a sharp decrease, like some of the other communities that have gone through this Omicron wave have experienced and been able to do. And I might secretly be hoping it's our last surge, but not necessarily planning on that either. So that's all I have to share today.
Thank you, Christy.
Thanks.
Dr. Abbasi?
Yes, thank you for having me. So I'm Cameron Abbasi. I'm one of the internists here at St. Francis, and all the partners have seen COVID. Obviously, we're all involved in this. Some of us have been seeing it from the beginning, and we've done nothing but COVID. So we do have a good point of reference respective to what we saw year 1, year 2, and here we are going into year 3. It's unbelievable. Last year was had a lot of hopes because the vaccines were out, and we were happy because we had so much death, so much mortality that first year. It was overwhelming. But then we were disappointed because, as you know what the Oklahoma's vaccination rates are, and not everyone has a choice, obviously, and it should impose anything on anyone. But I think it's, and I've mentioned this in previous interviews with, it's about social responsibility. I think everyone really has to do the right thing for yourself and, for your neighbor. I think it's the right thing to do. Patients were really sick. The Delta surge came Delta brought a lot of challenges that we hadn't seen the year before, a lot more complications that we hadn't seen before. And then here we are with Omicron. And although people may be a little bit more relaxed that it's Omicron, maybe it's not as severe, I can let my guard down. That's not necessarily true. Our hospital is overwhelmed. We are struggling. We are working hard. We love what we do. This is why we're here. And I wouldn't have it any other way. But we are overwhelmed. ICUs are busy. Those people who think that they can get away with this without getting a vaccination because I'll be fine, that's like playing Russian roulette, because you don't know. No one should try to get this voluntarily, to get it out of the way, take off your mask because I'm going to be fine. We have people going to the ICU today. Statistically, and I'm sure Dr. Robertson can present those numbers, from the state. What percent of what we're seeing currently is Omicron? What is Delta? I don't know. The patients that I'm treating in the hospital on an individual level, I don't know. Is it Omicron? Is it Delta? I treat everyone the same. But I still have people going to the ICU. They're getting intubated. And some are dying. That's just a fact. One of the interesting things I'm seeing this time around, many people are coming in delayed for care. Now, it's not because they don't want to come in, it's because maybe they had some symptoms that were not advanced, that were not severely progressive rather quickly, and so they may be here 10 or 12 days after onset of symptoms. There have been a lot of innovations in outpatient therapy. Monoclonal antibodies are there. You've got the option to get those antibodies so that you don't get sick enough to come and see me. Now you've got a newer antibody, which is more Omicron specific. That's great. Once you end up in the hospital and you're needing oxygen, it's too late to get those antibodies. Now, we have not had a lot of innovation in inpatient treatment, unfortunately, in the last year. What we had last year is pretty much what we have this year. We still have the antiviral drug remdesivir. We still have the dexamethasone. We have got some immunologic agents, and no one should really be counting on getting those because that means you're critically ill. The one thing I've said before, I'll repeat again, the one thing that's protecting you and me right now today is the vaccination. There's just no other way out of this pandemic that I can see without mass vaccination. Now, I'm not saying we should mandate anything. This is my personal opinion. I'm seeing worst case scenarios in the hospital, and I can tell you this is a disease of the unvaccinated. The people who are dying are unvaccinated. The people who are in the hospital for extended stays are in large unvaccinated. That is just a fact. That's all I can present to you as my plea to the public. Please get vaccinated. Please protect yourself, protect your neighbors. That's all I've got.
Thank you, Dr. Abbasi. We do have a question queue going, and it looks like Russell is first. Russell, can you take yourself off mute?
I unmuted my mic. I forgot to unmute Zoom. Sorry, guys. First off, I'll say thank you, not just for doing this, but for all you're doing. There are those of us in the community who realize that you all are in a war, and I just want you to know that we understand that. Moving on, I want to talk a little bit about supplies. It's come up that obviously that's an issue. There's supply chain issues with everything. But the FDA just took 2 of the monoclonal antibody treatments off the table. And I'm thinking that the third that still exists is in extremely short supply. Well, I know it is in Oklahoma and everywhere. And so I would think that you have to be very careful about how you utilize that and when, and it has to be just a certain amount of patients. But can you talk a little bit about that particular aspect of it, and maybe this is for Dr. Abbasi, talk about, well, if we don't have that as an option for somebody who's maybe moderately ill with COVID, then what should they do?
Well, hopefully you'll have a provider near you that does have access to the monoclonal antibodies. I don't know how far or how available the medication is going to be from Pfizer, and Merck was the first one to announce their pill. post-exposure prophylaxis. I don't know where and Dr. Robertson may have some information that I don't from the pharmaceutical standpoint. So that's one option. But if you have symptoms, I mean, obviously, as you've heard all along, we're extremely overwhelmed. We want you to come to the ER to get help if you need the help. But then it's difficult to educate the public about when not to come. I'd advise everyone to have a pulse oximeter at home. Watch your oxygen levels, watch your symptoms. If you feel like you're getting more fatigued, if your oxygen levels are going, by all means, come to the ER. This is why we're here. Go to your local urgent care. They can help you. But hopefully we don't get to a point where we have absolutely no access to monoclonal antibodies. But like I said, those oral medications from Pfizer and Merck may be the next step.
And as a quick follow-up question, then I'll let the rest of the queue jump in. Can we talk about, the next couple of weeks, I would think are key. We think we're plateauing. We hope that it's going to go down, but what signs are you going to be watching for that indicate that maybe we're seeing this latest wave start to ebb a little bit in Oklahoma?
I'll speak to that first, then Dr. Abbasi can speak to it directly. So obviously the leading indicator is the test positivity rate. So, we've been watching that in our own lab. It was up north of 62%, which was the highest we've experienced in the last 3 years. So the first thing is to see the number of positive infections or the relative positivity rate to begin to decline, because hospitalization and even those that don't survive, mortality are, as Dr. Abbasi and Christy know, are the lagging indicators. So even if our trend of 2 days, which isn't really a trend yet, if we're able to discharge more patients tomorrow than we admitted with COVID, we would start to feel a little bit better about hospital capability and capacity. But the real issue will be, when we stop seeing the number of newly infected individuals in the community. As that number starts to plateau, then we can expect a couple weeks more before the hospitalization pressures will let up. So that's the way I would answer that. I think Dr. Abbasi, though, could also answer your other question about the use of those, particularly for the critically ill patients, the use of the therapeutics. Is it not correct, Dr. Abbasi, that there are fairly specific protocols in terms of, who qualifies, how they qualify, and when they would be used? I think that's probably important for the public to know.
That is correct. A lot of this is not rules that we make. Much of this is mandated by the FDA. Keep in mind the drugs that we're using are emergency use authorization drugs. The two which are commonly used in the hospital, one's baricitinib, that's an oral treatment that's typically 14 days. The other medication is tocilizumab. It's a one-time IV drug and it's a one and done. Yeah, and the idea of the medication is to blunt the severity of the cytokine response. So, COVID, yes, it's a viral infection, but it's not like the flu. It's not like the common cold. You get sick for a few days and you get better. There is a domino effect that ensues once you get COVID-19. And if you're at risk for complications, and that's a situation that puts you in the ICU, there are specific criteria for those individuals who do and do not meet criteria for those. Again, there was a time you were experiencing shortage of that too. And, that can be very overwhelming for us as primary care providers or, intensivists and hospitalists. We want our patients to do well. What do you do when you run out of options? So right now as far as I understand, we have access and we have availability of these drugs. As Dr. Robertson said, once we get to a point where we're discharging more than we're admitting, we'll start to feel better as our volumes drop. What I don't want to see happen is people hear in the news that, oh yes, it's going to get better, volumes are dropping, and then you get complacent. Please don't get complacent. You've got to take your precautions.
Thank you very much, all of you.
Rick, you're next.
I had a few questions. First one is, you've seen some of the Oklahoma City hospitals say they have considered requesting the National Guard because the staffing outages were so bad because of Omicron? Have you all talked about needing outside help like that for yourselves? Or I did hear you say you moved some staff around. Have you, delayed any procedures or limited any procedures?
Christy, I'll let you answer a couple of those questions. I'll answer a couple of the ones toward the end. So first of all, to date, we have not delayed or canceled procedures and again, one of the lessons learned of the first year of this pandemic was a lot of the delays in care resulted in outcomes that weren't beneficial to patients. And so we've really been committed as a health system to maintain a stance to allow us to care for everybody that needs care. Now, is there a point where we could get to where we would just say, hey, we can't afford to keep running our ORs at the same level? Yes, that absolutely is a possibility, but we've not gotten there yet, and we're hopeful that we don't ever get there. I'll let Christy answer the staffing question, but we have about 150, a little over 100, about 150 different individuals who are travelers, contract labor, so they've come to us from other parts of the country, and we would take another 100 if we could find them. So using this contingent labor has been one of the strategies that all health systems have used around the country. The problem that we faced is we've lost staff to go travel because the way this is working economically, they can go make more money to jump on a plane and fly to a different part of the country and be a nurse or a respiratory tech for a 13-week contract. And so that's created this funny dislocation of staff where our own staff, some of our own staff, not a lot, but a significant number have left to go work somewhere else in the country. The National Guard, I don't think I wasn't directly involved in those conversations. I don't think we've been directly involved. And the National Guard is a little bit of an interesting sort of potential solution, because if you think about it, there are very few active duty National Guards who are just doing that job fully. These are all people that are essentially reservists. And so if you're going to activate nurses and physicians of the National Guard, you're just pulling them from existing health systems around the country. So it's not a net new. Maybe you could bring new resources to a part of the country, but that would be at the expense of doctors and nurses from other parts of the country that got called up. So I'm not sure that really is a solution for us. Albeit, if there's a certain part of the country that's hit particularly bad, you could deploy National Guard units from different parts of the country to go assist. That may be something that could offer some short-term benefit, but it's unfortunately they're not new resources. Christy, if you wanted to, maybe you could speak to just how your nurses are doing through all this, and the issue as far as staffing and overtime and all the things that you as a leader are trying to manage through.
Yeah, well, first of all, this is just what we do. We find solutions when we have problems. Our teams are incredibly smart and strong, but they are, for instance, Children's Hospital shared nurses with the adult ICUs, and the recovery room helped hold patients that couldn't get into the ICU. So it's all of us trying to figure out how can we share what we have. I know we're stretching our teams further than they've ever been before, but we're trying to do it as safely as we can as well. So the critical care units are sharing amongst themselves. The critical care nurses, if we ever have any extra, are going out to the COVID regular floors to provide a level of safety out there. And I mean, we are asking a lot of our teams right now, but we're just pulling together. That's kind of how we're doing it right now.
My next question, we've been kind of getting some messages about this, is some people have been showing up to emergency rooms for maybe a broken bone or another non-COVID ailment. And some of them have been tested for COVID. They test positive, and now all of a sudden they're finding themselves admitted for COVID, and they didn't even feel sick. Some of them have even said, I'd like to fight this at home if I have it. Are you admitting people like this? Do you have to, is that a part of infectious disease protocol? I mean, Dr. Bratzler told me yesterday, this is what OU Health does. So there's no guessing. It's everybody who checks in gets tested for COVID. And then unfortunately, if you test positive, you just get added to the state's tally of COVID admissions. I'm just wondering, is that your protocol as well?
I'd be very surprised. Let me reframe that. There are people that we will diagnose as incidental COVID because they've come to the hospital for a surgical procedure. And that does occur, and you hear about that around the country, that we are discovering people who might otherwise be asymptomatic based on our testing regimen for folks being admitted to the hospital. But I'll let Christy and Cameron, Dr. Abazi address. I would suggest that there shouldn't be a hospital anywhere in this country admitting somebody that is not sick. I mean, as you heard Christy say, we're spending time and effort making sure that we can get people, even folks that show up with symptoms in our emergency department. The vast majority of them don't require admission, and they actually get sent home. And so we absolutely aren't admitting people that don't require hospitalization.
Right. And I would say we're even triaging those that are in the queue to be admitted to see, is there any other way we can help them get back to a home setting? Because isolation at home is probably way more comfortable than being in the hospital if it's safe for us to do that. We're not testing every single patient that comes through the emergency room. We have a few protocols for high risk areas that patients come from if they live in a group setting. Those patients are probably at greater risk for having been exposed. So we have some protocols in place, and actually there is a segment of the population that we are finding it when we're trying to place them into skilled nursing facilities or rehabs here in the community, where the outside facility requires a COVID test to be negative before they can actually discharge. So there's a little bit of that surveillance testing for those purposes, but routinely, if you don't have symptoms, I am not seeing a trend of people being tested for COVID unless they're symptomatic or starting to have failure here at the hospital. Patients come in though and are testing for positive for COVID and have other medical problems, may have an orthopedic injury, may fall because they were syncopal and they broke their hip. And so we have patients that I would say they're really on the asymptomatic or very mild COVID. They didn't even know they maybe had it, but it was discovered. We are treating their primary medical condition and providing them the appropriate isolation from infection prevention while they're here at the hospital. We still hope to get them out as soon as possible. If they're ready to discharge, we want to do that safely.
The last numbers I saw were we are about of the patients that we've identified with COVID that are in our hospitals, 90% of them are in the hospital for COVID. There is an incidental, as Christy was just mentioning, and it's about 10% of the number of folks that actually are admitted for another reason, but also have COVID at the time of their admission. The other thing that we are continuing to track, and what we're seeing, which is consistent with other health systems around the country, is I think the data yesterday, 81 or 82% of the patients admitted for COVID were unvaccinated. So there are, so 18 or 19% of our COVID inpatients have had at least one vaccine, or in some cases more than that. So we fully acknowledge that being vaccinated, fully vaccinated, is not a fail-safe, but as Dr. Abbasi pointed out, the risks of getting significantly ill, severely ill, are substantially decreased in those individuals that have chosen to receive the vaccine. So that's another important message that we do just want to keep delivering as frequently and often as we can.
Yeah, just to reiterate what Christy and Dr. Robertson have said, I mean, COVID is all I do. And no, I have never admitted a patient simply because they were positive for COVID-19. They were here for some other legitimate diagnosis, which is, as Christy mentioned, the reason that they're here. And it just so happens they've got COVID. And so we have to protect our staff members. We have to protect others so that we don't transmit. And that's why they have to be kept in isolation. But to admit them simply because they have COVID, I hope no one is doing that. We certainly are not doing it.
Thank you. Amy, you're up.
Hey there. I'm wondering if Christy could circle back to what she was talking about, seeing the trend of young expectant mothers. That's wonderful. She gave that example of the woman who was 6 months pregnant and is in rehab now. I'd love to share that with our viewers, but can you talk more broadly about the trend you are seeing? Are they coming in mostly unvaccinated? What are you seeing? And then secondly, just a quicker question about testing. A few weeks ago, we had been reporting that the site out at Broken Arrow that y'all have, there was about 800 a day, if I remember that correctly. Can you talk about any update on that? What kind of numbers are you seeing for people getting tested? Thank you.
I'll go first. So I would say it was probably after the holidays, after we began our this surge, that we saw more expectant mothers than we have seen, and most of them are unvaccinated. Nearly all. I don't want to say all because I don't have the specific data, but it's kind of as the baby was growing or as the mother was infected, the difficulty for the mom to breathe, plus as it just stressed the body. The patients had other comorbidities sometimes, but not always. Again, the goal was to oxygenate both, get enough oxygen for mom and the baby. And there was a couple of them we were able to keep off the ventilator, and several that we had on a ventilator. As you can imagine, those are the kind of cases that really still kind of hit to our heartstrings and wish we were never having to prone a pregnant woman in order to take care of her and make sure she survives. I will say I was so impressed every time we would do something dramatic like that for our patient. There would be an OB physician, we would have labor and delivery come over. We did everything we could to help, physically care for the patient and keep the mom and the baby as safe as possible. But there was nothing, I know I used the word nothing normal in the previous interview, but there was really nothing normal about having a baby isolette in the hallway and a C-section delivery tray in the ICU. And so that was what, it was so scary. So we are just, again, so thrilled that, at least for that particular patient, she did eventually get out of here and is recovering. But yeah, mostly unvaccinated, and then kind of the pressure on the lung as the baby's growing and the stress on the mom's body.
And then in terms of,
I think the other question was about testing. And, so we have seen a little bit of a decline in the number of folks that are coming to our South Tulsa site to be tested. But I think our 7-day rolling average is still in the mid 500s. So roughly 550 or so folks a day. I think what the public health department has done here in Tulsa to help promote and advertise all of the locations that folks could go to receive testing, I think that's helped. And so I think that's a good sign, but we also are very much encouraging folks who are having symptoms to consider getting tested, because for some people, they don't get critically ill and they can ride this out at home, and that's great. But the most important thing is the information, knowing that if you do have COVID, you need to think about how you isolate yourself maybe a bit differently than you would have 2 or 3 years ago. So we very much encourage people to get tested if they're feeling ill.
and I'll add to the number that Dr. Robertson mentioned, our 7-day rolling average last week was 740, compared to the current, which is 550. So that is promising.
Thank you.
And Chris Polansky is up next.
Thanks so much. Thanks, everybody. I've heard from a number of other hospital systems in the state who've described over the course of the pandemic having patients, both COVID patients and non-COVID patients, who have sadly died waiting for care or died waiting for transfer to another facility. Have you had that experience at St. Francis of just being so overwhelmed that folks aren't able to get the care they need at times?
I guess we can fall back up, but I'm not aware of that. I'm not aware of any situation. We are aware that there have been outlying hospitals, not part of our system, but community hospitals that have had patients that they were trying to transfer, and we just were not in a place that we could accept them just because we were already, exceeding capacity. And that always makes our team feel sad, because we do see, one of the roles of St. Francis Health System, and particularly our tertiary medical center here on the our Yale campus. One of its roles is to be there for these communities, these outlying communities, to be able to care for patients that can't be cared for close to home. And so that we know that's an issue, but I'm not aware of anybody inside our system not being able to receive the care that they needed and or were eligible for.
Thanks. And second question is just kind of speaking about transfers. I mean, how far away are you seeing patients that you're accepting as transfers coming from? And have you had to send folks to out-of-state facilities at times?
Christy, I might see if you just anecdotally, since you're in the ICU, you have a sense of where folks are coming from, and I guess same for you, Dr. Abbasi.
I feel like they're really still in Oklahoma, northeastern Oklahoma, and the bordering areas. We're not getting patients from Oklahoma City, for instance. So I think it's still our region that we're mostly accepting patients from. I've heard other hospitals, smaller hospitals that are not in our system. Some of our staff work for the flight companies, and they were sharing how far they've gone, which is usually a state or two away, if due to transports for some patients. But we're usually the receiving end of that. So it's very rare that we are transferring somebody out from St. Francis. We're able to mostly care for you here, unless we need I call it the most intensive critical care COVID intervention of the machine that oxygenates your blood. So outside of that patient population, we've mostly been able to care for them here.
We do have times where there are internal transfers. It's one of the benefits of being part of a system is if one of our non-Tulsa based facilities need to transfer a patient here for care that's not provided there, they can do that. In the same vein, if there's someone who can be treated in a lower level of care and open up a bed here for someone that's going to be transferred in, we can also do that. So there are internal transfers.
And I'll just add one thing to Christy's comment. So, one of the things that is a byproduct of this experience over the last couple of years is that St. Francis is in the process of developing its own ECMO capability. That was what Christy was just referring to. That's the ability to, when somebody's in severe lung failure and you need to oxygenate their blood because you can't utilize their lungs, it's essentially a heart-lung bypass type machine. We did not have that capability for adults at St. Francis, but by this summer we will have a program set up, and that is again just an example of St. Francis's commitment to the community and being able to serve all of the healthcare needs for those folks that need the service of these amazing professionals.
Thank you all so much. If I have time for just one quick one, and specifically for Dr. Abbasi and Christy, just from the provider perspective, can you talk about just the human toll this is taking on you guys and your teams, and how you're managing. I know you're getting creative, but it's challenging. I heard each of you say, what does that look like for folks?
From the physician perspective, I can speak to that because I've done nothing but COVID since this began. The first year was extremely hard. Every year is hard, but we have never seen death like this before. This is what we do. We signed up for this. We provide the best care we can for our patients, and we're committed to that. But then feeling helpless that you want to do something, and then they die, and they die, and they die. That takes a toll on you. First year, I can tell you, I can't speak for my partners. I can tell you about me. I did not do well. But you have to keep moving. You have to keep taking care of your patients. They need you. And you keep fighting and you keep doing what you need to do. And that goes back to the point I made earlier. The one thing that's preventing this mental and emotional toll that we're going through are the vaccinations. I mean, we can be in the hospital and we can talk about all the innovations in healthcare and the medications, but patient lives are patient lives. That's bigger than anything else we can talk about. And how do you preserve life? We're here to help preserve life. And it almost feels that at times we failed, not because we didn't try. And that is emotionally taxing. So there's that.
So I'll start with the disclaimer that my husband told me last week, probably as it was in the heat of the moment, that I'm one of the top 5% resilient personalities that he's ever met. So we have to lean on each other. I've been here 20 years and I've never been so proud of the teams we have and how we're having to honestly hold each other up, because yes, it's very real what Dr. Abbasi says, and all of those emotions the staff have felt, and physicians and nurses, but that's part of why I emphasize we come here for each other. Because our job as caregivers is we care for each other as we go through really tough times. And it does feel like the teams we've gone through fire together. And I think as much as the pain is right now, we will be stronger at the end of this. And we've had great support from the hospital when it comes to offering some of their support services for those who are struggling the most. And we have paired staff up with those resources and maybe made adjustments to people's jobs and schedules because they need a break. They need to be able to have a rest, maybe get some family time because their cup is empty. So the staff are, we've got a wide range of personalities. So the happy of us are trying to keep those of us who are really on the downside. But, we didn't get into this work because it was glamorous, and we are here because we care about people, and there are people that need our care. And I'm, again, so very proud of the teams that are truly showing up every day to do this. Us as leaders are trying to keep a good pulse on where they're at and help keep their minds and their hearts in a safe place. So
thank you so much for answering and for all your work.
Thanks.
Thank you. And Corey, you're up.
Thank you. I appreciate you all doing this and all your words and insights. And I have kind of a follow-up that's a twist on what Chris asked. We're looking at record hospitalizations right now for COVID in St. Francis, Tulsa County, and the state. We're almost 2 years into this pandemic, and the vaccine has been widely available for almost a year now. And I know unvaccinated COVID patients still get the same level of care. You're trying to help everyone. But what does that feel like at this point in time when another unvaccinated COVID patient comes in and you have to talk with them and treat them? Is there an extra long sigh, deep breath? Is there an added level of exasperation at this point?
Yes, but you know what? It's not my job to judge anybody. Everyone has a personal choice. Everyone always has a choice, and you can choose not to do it as long as you understand the consequences of your decisions. But you know what? My patients, vaccinated or not, they will always get the same care and they will get the same amount of compassion. I will try equally hard for every single one of them. But the only thing they can do to help me help them is to go get vaccinated.
And if you don't mind me stepping in again real quick, do you feel like the vast majority properly understand the consequences, or do you think a lot of people it's the misinformation out there?
I think there's a lot of misinformation out there. I think there's a lot of unnecessary self-confidence out there. I don't mean that in a rude way. That's as plainly as I can put it. There are some patients who just feel like, I never get the flu. I never get the flu shot. I've never had the flu. You know, this is COVID. It's just another virus. Well, hopefully you've been keeping up with, you know, the death statistics over the last 2 years. We've had, as you mentioned, we've had the vaccine for a year now. The only thing you can do to protect yourself right now is to go get vaccinated. Like I mentioned before, yes, this is Omicron. Maybe it's not as bad, but who wants to roll the dice and try to get it and find out if you're not the one who's going to do well? I mean, the care I'm going to provide is going to be the same, irrespective. I do ask all my patients, are you vaccinated or not? Because I need to know what to expect as a hospitalization goes forward, because those who are vaccinated, they may have breakthrough infections. They may be in the hospital. Generally speaking, they're not going to do poorly. They may be with me for a few days and they'll go home. Whereas those who are unvaccinated are unlikely to go home as quickly and more likely to have severe complications.
Could I add in a little bit? So I'll just use a personal example. Both my grandparents had COVID last week or a week and a half ago with this Omicron wave, and we're talking 89 and 90 years old. And there was an assurance or less fear that I might have had as a practitioner, knowing that they had the best protection of vaccination inside of them. And they were hopefully going to have as mild of disease. But at the same time, there's also, I think, for the patients that get COVID, some coaching that we can do to the community to help them stay out of the hospital, which are to not lay in bed the whole time, get up and move around, take deep breaths, cough, deep breathe, roll on your tummy and hold your breath for a little bit. Do the things that you need to do outside of the hospital. Stay hydrated. Drink when you don't even have taste and your throat is sore. Doing those things to also help prevent if you get Omicron or Delta or you get sick with COVID. Any patient, vaccinated or not vaccinated, we want the patients to do what they can outside of the hospital to try to keep them from ever even coming into these doors and dealing with the pneumonia that comes after COVID. Sometimes that's really some of the most devastating cases I've seen. So happy to say we kept both grandma and grandpa out of the hospital. And grandpa even came to the ER and I told him we could take care of him at home. So, you know, it is something that the vaccination and knowing my family is vaccinated really did truly kind of give us peace to not worry as much. But equally, there was, you know, coaching that we're not going to just lay in bed and get sicker. We're going to do everything we know to do to try to stay as healthy as we can while we're facing the beginning of the illness. So I wish we could coach more people on that they would know how to do those sort of things in order to stay as well as possible.
I appreciate that, both of you. And Dr. Passara, as a follow-up to that, can you kind of help?
Nurse Passara.
Sorry. I'm just trying to help out, you know, right? Little bit of a promotion. Anyway, can you walk us through what some of that does to help the coaching you're talking about, the don't lay in bed, the get up, the move around, the deep breaths, the coughing? Can you kind of walk us through how that helps a patient?
Well, I or any of the physicians on the call, feel free to call in to chime in. But yeah, one of the things we know is if someone lays still, then things have a chance to just sit there and get worse. And so the more a patient can move, the more they can cough, take deep breaths. The laying on your belly gets the back of your lung to have more air, and it just kind of keeps things moving. That's the whole point, is to keep oxygen going into the body and keep those lungs as clear as they possibly can. And that includes partnering with your provider. Like, reach out to your doctor and get some guidance, and whatever we have in the community to offer, whether it be therapy, have those things followed, but equally, don't forget to eat, don't forget to drink, don't forget to, of course, get rest. But I do hope that people can get up, walk around, so they don't get a blood clot in their leg. It seems simple, but the more people can move, stay hydrated, and again, help protect their lungs, probably the less severe of an illness we're going to see on the inside of the hospital too.
Yeah, I think that's very accurate. Especially with COVID that we've seen within the last year, since the Delta strain, which is going on a year now. I think March last year was the first time we saw that. The propensity of DVTs, blood clots, have gone up substantially. So it's very important, if you're ill at home and trying to take good care of yourself, that mobility is extremely important. Hydration, diet, I completely agree, very important. The reason the deep breathing helps is because most of the complications that I deal with in the hospital that have to do with respiratory illness, there's a lot of inflammation going on systemically in your body. And the fact that it's affecting your lungs is why your oxygen level can be low. So that's where the deep breathing comes in. Lots of deep breathing, lots of voluntary coughing. You want to keep those lungs nice and soft and pliable and compliant. So that's the benefit of the deep breathing as well.
And I just would add one thing. Maybe there's been more media attention because it's a global pandemic, but please recognize that those of us that live and work in healthcare, we have dealt with this issue of patients making unhealthy choices. We've dealt with that forever. I was a family physician for 20 years. I used to wish that my patients would stop smoking, or would exercise, or would put a helmet on their child when they were on a bike, or would drive with their seatbelt. I mean, this one is maybe a little bit more focused, and it's more sort of short-term, real time. But people in this country and in this world make unhealthy choices all the time, and yet we are still committed to do the absolute best for them, regardless of their beliefs and their choices. And so you do have to, and I hope you see it the way I do, that for folks like Christy and Dr. Abbasi, you understand the amazing humans that they are, that they work 24 hours a day to take care of folks, and don't let the individual's choice or perspective impact how they deliver care. And that's what makes healthcare a very special profession. And these two represent a large group of very special professionals that work in healthcare all over the United States.
Thank you, Cliff. And we have one more question from Rick.
So I'm back to work after having COVID for a week and a half. I know a lot of Oklahomans are returning to life. I think a lot of the questions we have is, what now? Is this over for us? Do we go on our cruises? Do we have our house parties? Is this over? What are you telling folks when they recover? What do we do now? Is the pandemic over for us?
The pandemic is not over. If you've had Omicron, which is more than likely what you had, I personally got over COVID a week and a half ago. I was out. I was providing care to my patients. I contracted it. My wife got it. My kids got it. Here we are. We're over it. The pandemic's not over for me either, simply because I had COVID. Statistically, and you can do your research, recent publications are out there. The people who are there who are most well protected are those who have had COVID and have been vaccinated at the same time. If you only have COVID and have not been vaccinated, all bets are off. You can get it again, and it could be catastrophic next time. So no, the pandemic's not over. For those who feel confident that they've had COVID and now life can just go on as usual, we pray that that day would come. I think we're all praying and waiting for that day. But simply because you've recovered from COVID, that day is not here today.
Thank you. We are coming up to the top of the hour. Dr. Robertson, is there anything you'd like to add before we close?
You know, I guess I would ask our colleagues in the media just to continue to do what they're doing, which is sharing the story of professionals like Dr. Abbasi and Nurse Passara, because they are, you know, there are community members and they're incredibly important. And while we as a health system can do the things that we're doing to try to recognize and reward, I mean, we've done bonuses, we've given substantial raises, we've done those things. What's equally important is just the community support and recognition that this pandemic, it isn't over. And yeah, while we're all tired of it, there are still thousands of people in this town, in this community, that are getting up every day and facing the very difficult tasks of taking care of very sick patients that have been infected with this virus. And so we can't lose sight of that. So if you see somebody that you know that is a nurse or a physician or even works in a role like mine, which is to support our frontline healthcare givers, you know, pat them on the back, say thank you, because that is incredibly important. And I do worry that we've sort of let that fall by the wayside over this last year and a half. And I do know our teams would greatly appreciate just that simple recognition.
I'm going to listen to my boss and say thank you, Dr. Abbasi and Nurse Passara, for joining us today. Thank you all to the media for covering this topic. It's still important, and we will see you next week.
Thanks, everybody.